summary, I've used this Wilson-Younger criteria, which is accepted by the World Health Organization, to use as a paradigm for evaluating melanoma as a target for screening. And here are the criteria to assess the validity of a screening program. We have a condition which is a very important health problem. I think everyone agrees. The natural history of the condition is to be well understood. And there should be a detectable early stage. We'll review that. And treatment at this early stage should be of benefit than at a later stage. And I think it's well established that in melanoma we can use Breslow thickness as a predictor of outcome. So we'll be able to talk about that proxy in this. The suitable test should be devised for this early stage. By tracking and mapping the skin, we're able to appreciate where the cancers may lie. I'm the owner of this device, and this device has been in use for quite a while, and it integrates directly into phototherapy booths, and we capture 65 different camera views, but we're actually doing a video mode, so there's quite a bit more information that's flooding through the system than ever before. And 1 out of every 200 spots that we detect are actually melanomas in our population. The test should be acceptable. We've looked at this in terms of the patient's acceptance, and it's quite high. And we've also looked at repeatability in terms of when we need to scan people. We're also talking a little bit about the health service provisions that would be made for the extra clinical workload. That's obviously a problem. We talked with a number of people at the meeting already about the clinical workload that's involved in melanoma screening. It really is something that is quite a burden to us in our practices. We know that melanoma is causing a lot more trouble than prostate cancer, a lot more, because it's a young population, average of 20 years of life lost, 144,000 qualities lost to the comparison of 112. Prostate cancer, 4 years at the old in the old man's life. Now, we've been doing this for 19 years, so we've got an enormous collection, and it's actually the dermoscopy images are, I think, 3 times larger than the Spanish Barcelona group, which is quite famous for this. Now, this is one of the early things that we published back in 2006 at the Society for Investigative Dermatology, and we found that serial scans, this was just kind of the beginning of our research. You can see here that the melanomas are in situ if you catch them and scan them frequently enough. So you've got a great opportunity to turn melanoma into a harmless disease. And here we see the comparison with visual skin examination. On the pie chart, you can see the proportion of small melanomas represented by the light green versus red melanomas, which are greater than 6 millimeters, which are in red. And you can see the difference in the melanoma diameter for every single amount of melanoma or size of melanoma removed. It's going to be removed that much quicker with the screening program in place. And we've actually got quite a nice reduction in the biopsy rate, which makes it very affordable, and that reduces the clinical workload resulting from screening. And the doctor's time is just the little red blip at the end, so we could even minimize that further by simply having the doctor take a look at the resulting dermoscopies. The whole protocol is that we look at the time-lapse changes with technicians who are highly qualified and constantly tested with quality assurance, putting little faux melanomas on their skin to pretend and to see whether they miss them or not. Obviously, challenges of large-scale screening remain, namely that we don't have the workforce available to do all this, and that's why we're looking towards things like artificial intelligence and on-site employee screening.